Okay, everybody, we're gonna get started. Good afternoon and welcome to weekly conversation regarding reopening strategies and how they've been evolving since the spring. My name is David Sturts with Cooperative Strategies and been doing this weekly conversation in partnership with Mary Falardo and the National Council for School Facilities. Unfortunately, Mary could not be with us today. Please, if you know her, send her well wishes. She had some orthopedic surgery today, and so she has other priorities, but she will be back in the saddle with us here next week. Please send her your well wishes when you have a second. We are grateful, honored to have Dr. Lauren Meyers with us today from the University of Texas, Arlington, mathematical epidemiologist, who's going to provide us on the school side, on the school operations side in particular, and insights into how to think about this virus and its spread and prevention from an epidemiological perspective. And then we are also pleased to have Dr. Julius Monk and Bill Cooper from Durham Public Schools and from Milford Public Schools, North Carolina, New Hampshire, respectively. And we're going to engage in conversation about the specifics around their reopening strategies with Dr. Meyers and have an operations and scientists discussion here. So I'm looking forward to hitting mute button on myself and listening on this round. So as we get into it, here's our speakers for today. Please do stay on mute. As you have questions or comments, please insert them in the chat and we will get to as many as we can here by the end. The meeting is being recorded and we'll post this to the website along with every conversation. The objectives today, better understand public health thinking around reopening and focusing that conversation on specific examples rather than sort of theories. And so that's why we have Julius and Bill with us today. And looking at, of course, keeping the virus out and stopping the spread if and when it gets in. And then exploring what this looks like and means in two very different contexts, a mid to larger size district in Durham and a smaller district in Milford. They share some commonalities, though, and we'll get to those here in a minute. So I'm going to introduce each speaker a little bit more detailed and allow them to introduce themselves and do that here in the next few minutes. Go over an overview of the districts that we are going to focus on today, and then sit back and have the conversation between Julius, Bill, and Dr. Meyer, and wrap up with some closing thoughts here. So let's get into it. Dr. Meyers is professor of integrative biology and statistics and data at UT Austin, trained as a mathematical biologist, and has written extensively on this topic. So if you have not yet, you want to read what she has put out in terms of understanding spread and the math involved in how to think about this, please visit her website on UT Austin, and you can see links to a lot of those articles. Very informative. And again, we're honored to have her on the conversation today. Dr. Meyers, welcome.
Thank you. It's great to be here.
And Dr. Julius Monk, COO of Durham Public Schools, been executive director of facilities at Guilford Public Schools prior to that, and worked in all the trades in school districts in the Carolinas, and he's been a frequent contributor on this webinar. Julius, good to talk to you again.
Good to see you, David. Thank you for having me.
Yes, sir. And grateful Bill Cooper, first time on the webinar, 37 years in facilities management, 17 in the current position in beautiful New Hampshire up there. And connected through Amy Clark from the state to New Hampshire, has been a frequent contributor to the webinar as well. So a lot of expertise on facilities, on school operations, and on epidemiology in today's conversation. Bill, thanks for being here.
Thanks for having me.
Absolutely. Okay. So real quick, and then I'm going to sit back in the conversation. But what are some commonalities and differences? Milford, smaller town in Hillsborough County, which is a larger county, but the town itself pretty small, 15,000 in Milford, New Hampshire. Durham, about 300,000 in the city there. school population, you're about 2,400 in Milford and about 32,000 in Durham. Average school size, we're small, about 300 and 800 school size in the elementary level, 700 middle, and 850 at the high school in Milford, and averaging 500 in the mid 600s and about 1,500 at the high school. Strategies for social distancing, very similar. About a third capacity operating the buses to allow for, rather than 3 kids a seat, 1, staggering the seating there, 36 plus square feet a kid to allow for social distancing in the classrooms. And everybody's wearing masks all day. Some mask breaks, but that's ubiquitous. And so let's start up here with Bill. If you want to explain just real briefly, kind of what are you looking at from a facility standpoint, opening up some of the conditions that you're dealing with and the challenges that's presenting you, and then Julius, you could follow the same.
Yeah, so in Milford, we're running, our oldest building was built in 1894, has no central systems at all. And we have to use fans to exhaust some of the classrooms. We put in window air conditioning units to actually cool them down for the last couple of years. The other schools, they're built in 58, 61, 72. There's not a lot of air conditioning in any of these buildings. There is central systems, but it's mostly rooftop air handlers, just so that we can heat the space and move some fresh air in. The biggest challenge we're going to have is air quality. We're hearing a lot of different ideas or guidelines that we don't know which ones to follow. And I think that's the norm. So we're not sure what we're going to do. So.
Thank you, Bill. Julius.
Yes, thank you. And much like Bill, we have older buildings. Our average age of our buildings are 44 years old. They span all types of different HVAC equipment. In the South and North Carolina, it can get very humid. We experience every season, sometimes in the same day. So that makes it really challenging for our HVAC equipment. Some of the guidelines that you hear about opening up windows, some of our, we already battle indoor air quality as it is. And so the different pollutants, whether it be from traffic or pollen or even noise pollution as it relates to, trying to keep students concentrated on learning, poses a problem whenever you have windows open. And then, we don't have many buildings with that introduce fresh air as a part of the system. And a lot of these older buildings were built with returns on the interior walls and unit ventilators, or even rooftop units that had diffusers that were quite a distance away from that, so that you would circulate the air by drawing it back in with the returns. Normally those returns are near where the teaching station is. And so it matters how air travels through the room and what's being introduced, whether it's by aerosol or even droplets. And so those are some of the issues that we see from a mechanical and operational standpoint. And then the desire to have a better filtration system. But again, these units were never designed to have a MERV 13 filter, for example, and they would literally shut off if you tried to suck air through them. So these are real challenges, and obviously you can't replace them all at the same time before school starts.
Right. So So very different districts, but some similar challenges there around concerns around indoor air quality, and really looking grateful. And I neglected to mention that Dr. Meyers is able to join us here. She through NASEM, National Academy of Science, Engineering, Medicine. She was an advisor to NASEM in their report that we've referenced, and grateful for the connection there through that National Council for School Facilities to NASEM to bring Dr. Meyers on. And so looking at, obviously, Dr. Meyers, we're going to you're welcome to share your screen. I think you mentioned that would be the best way to do it now. So Dr. Meyers' expertise is looking from epidemiology, looking at this virus as it spreads, and a lot of our concerns in school districts around the country right now is around indoor air quality. And so what's the intersection there? And so looking to appreciate Dr. Meyers' presentation now and discussion on just sort of the 101 on epidemiology, how she looks at this virus's spread. And then we'll get into specific questions that Julius and Bill have presented regarding indoor air quality and regarding social distancing and other things. So Dr. Meyers, the floor is yours.
Thank you. It says I'm not able to share my screen until you stop sharing yours, apparently.
Yep, I will do that then.
Okay. All right, thanks. This looks like it's going to work. Okay, good afternoon, everyone. Thank you for inviting me into this discussion. I'm going to very briefly just kind of give you a sense of what we usually do in our science, and I will just start with a caveat that I really don't have a lot of specific expertise on how to manage indoor air quality, circulation, ventilation to ensure the health and safety of students during the COVID outbreak. But I have read a lot on it and have a lot of other kind of perspectives that I'd like to share about ways that we should be thinking about if, when, how many kids and staff to bring onto campuses in various communities. So with that, let me just start by putting up a couple figures that are images taken from the kinds of models that we build in my lab at UT. So we have been for many, many years, a couple decades now, building models that project how different kinds of epidemics and pandemics will spread through our communities. What you see on the left is a video of an app that we developed for the state of Texas following the 2009 pandemic. And it was an app that simulates different pandemics spreading through the state of Texas, and the user can specify how deadly it is, how infectious different people of different age groups are. The user can implement different vaccine and drug and school closure and other social distancing measures and see how they'll play out in a simulated pandemic. And these kinds of models are meant just to give kind of intuition, quantitative guidance to help public health agencies and other leaders prepare for future pandemics, make sure they have enough resources, make sure they have game plans for what they're going to do. The image on the right comes from a project that we had started with the CDC in the fall of 2019, so less than a year ago or about a year ago. And it was basically a project to take what we've been building for Texas and extend it to a national scale. So to build a large model of a pandemic spreading through the United States where we could change different parameters, different characteristics of the spreading virus and use it to come up with good plans for how we would respond to future pandemics, how we would detect future pandemics, all the things we wish we'd done better in COVID. And this project, which CDC funding, was one of 5 different models that was being developed in parallel.
Tommy.
They're not in there.
Oh, okay. Oh, okay. All right.
I think I was muted. Okay. Can you hear me now? Okay. So so we were doing this with other groups around the country to get ready. So these models weren't ready. And even though we've been doing this kind of work for decades, and others around the world have been doing this kind of work for decades, and even though we do have pretty good plans in place for the next influenza pandemic, COVID caught us by surprise because for a couple reasons, it's turned out to be really hard to contain. One is that it spreads very quickly and silently. And the other is that we don't have a 6-month pipeline for a vaccine like we do for influenza. So, and so a lot of my work, just so you understand my expertise, is really thinking about things at a population level. How do we deploy drugs, vaccines? When do we close schools? And also a lot of my work is about building models that can actually forecast, how many cases are we going to see next week? When is the current wave going to peak, et cetera. So that's where I'm mostly coming from. Yet a lot of the discussions that we've been having over the last few months has been specifically around what are we going to do about schools starting now, basically, when in a situation where it's very likely that there's going to be a lot of heterogeneity and risk. Some communities are going to be in a situation where it's going to be very difficult to open schools for a variety of reasons, and other communities are going to be in situations where it's going to be a little bit more feasible. And so how will we know when, how, who, to bring to school? So let me just, I'm not going to dig into too much of my own research, but I'm just going to mention a couple very early studies that we did that helped us all just to understand the nature of this beast. So one of the very first studies we did was not a fancy modeling project. It was just a simple analysis of data. So this was really in early February. We worked with a team of Chinese students who went to websites of 18 different public health departments across China. And they looked for case reports that basically had a few pieces of information. So this was someone who came down with COVID, and the case report specified what day they started developing symptoms. And then it also specified who likely infected them. And most case reports, you don't know that. But these were cases where there was a good indication. For example, it was one of the first cases in a city. The wife gets it. And it turns out the husband had just returned from Wuhan. And so, you can kind of connect the dots and figure out who infected who. So, and then we also wanted to know what day the infector first felt symptoms. And so we ended up finding about 450 different case reports that specified the infector, the infectee, and the date that each one of them had symptoms, first felt symptoms. And what we looked at was what is the time between that infector first feeling sick and the infectee first feeling sick. And the number of days is called the serial interval. And all we did was simply plot those serial intervals. So this is a histogram. It's just showing the distribution of those intervals. So the value of 10, just telling you how many of those cases had 10 days between the first case feeling sick and the second day feeling sick. And the negative values mean actually that the infectee felt sick before the infector. So when we plotted this data in February, it was a real oh no moment. And why was that? Well, this was before we really knew much about this virus. And the first thing we noticed was on average, it was about 4 days between somebody feeling sick and the person they infected feeling sick. That meant that this virus was spreading about twice as fast as that original SARS virus from 2002. So that was one of our first indications that this thing was going to be blazing through much faster than SARS and make it more difficult to contain. This was the most concerning thing, was these negative values. This meant that a large number of cases that were infected were actually infected before the infector knew they were sick. They felt perfectly fine prior to symptoms. And now this has been established. But when we made this graph for the first time and we shared it with our colleagues at the CDC and other researchers, everybody said, oh no, you must have made a mistake. This can't be true. And then, certainly other data very quickly became clear that this was a real thing, that people are actually highly infectious before they even feel symptoms. And this is what makes this virus so stealthy, what makes it really difficult to know if you have infected people in your community or showing up at schools. And then there was also this aspect of it sometimes you see these long serial intervals, which means that people may still be infectious a couple weeks after they first feel sick, which means that we have to have these longer quarantine periods. So that was an early study that just kind of helped us to understand what was going on. And still today, it's these three things: fast, silent, and sometimes long, that are dictating why we have to take the precautions we have to take when we're thinking about bringing kids to schools and teachers to schools. The other thing I will just mention, this is a study that really is looking at, does it matter how early we take action? Like let's say that we think there may be a case in a school, or we've detected one case in the school. Should we send people home the next day, or should we give ourselves a couple of weeks to see if more cases show up before we send kids home? And what this study suggests is that it's a good idea to take action as soon as possible once you actually have the start of an outbreak on your hands. This data we're also data from China. So a lot of this work was done when the only data available were from outbreaks in China. And what we did is we had data from 58 different cities. In each one of those cities, we made a graph like the one you see on the top. And all that is like you're going through time, and it's how many new cases are reported each day. In this case, a blue case means it was a case where they believe the person got infected in another city and then came home to this city. And red means it was a case that was probably infected locally by someone who was infected in town. And so based on that case data, that epidemic curve, we can estimate something called the reproduction number. That's what you see in the bottom graph. We call it RT. And the way to think about the reproduction number is it's if somebody's infected, how many people are they likely to infect? So if the reproduction number for the virus is 2, that means that every case is infecting on average 2 other people. And the way, and you see through time, this reproduction number changes. It starts coming down through time. And there's 2 ways a reproduction number changes through time. One is that if you don't try to mitigate an epidemic and you just let it start spreading, eventually enough people become immune that there's not a lot more people to infect. And so then the reproduction number starts declining just because there are not that many people left to infect. But the other way, and what you're seeing here, is that it can decline if we take interventions that stop transmission, that block transmission. When we wear face masks, when we stay home, all those things make it less likely that someone who's infected will infect other people. And so in this case, this curve that goes up and comes down for this particular Chinese city, and then this reproduction number that comes down and eventually goes below 1, that's the impact of these very draconian social distancing measures where, everyone stayed home, like the ones we eventually implemented in the United States. There's a horizontal line there at the reproduction number equal 1. That's a critical threshold. When a community succeeds in bringing the reproduction number under 1, then we expect that every person who gets infected, they will not even infect 1 other people. So once the reproduction number comes below 1, we expect that the virus will burn its way out without causing another surge in cases. And so the question we asked was, we looked at when did these cities, these 58 different cities, implement their first social distancing measure. So here you can see there's the first intervention in the city on, I don't know, it looks like January 23rd. And then we asked, how does that relate to how long it took for this community to bring the outbreak under control? How long until they brought that reproduction number below 1? And what we found when we compared this across many, many different cities was that every day the city waited to implement the intervention, in terms of how long after they detected their first case, how long did it take them between the first case and implementing the intervention. Every day they waited led to 2.5 more days of having to fight the outbreak before they brought it under control. So, and maybe in terms that are more relevant to us, if we wait a week to enact a measure, we might have to keep that measure in place for an extra 2.5 weeks before we can go back to life. So every day matters. And that doesn't mean we need to, before you even see an epidemic, stop all social life, but it means at the first indication that you have something emerging, it's better to take action earlier than later. Otherwise, not only you're going to have more disease in your community, but you're probably going to have more economic and social hardship because you have these measures are going to have to last longer. Okay, so now that's just to give you kind of a flavor for some of the key epidemiological things to think about, a little bit about my own work, and now I'm going to feedback from someone. Now I'm going to pivot and talk about schools a little bit. And a little bit of the thinking that we've been doing in helping our local school districts and school districts around, particularly in Texas, think through some of the issues. So, this is actually done the wrong way, but there's basically 3 key kinds of risks. Or at least the way we think about it. There is the risk that students and staff will arrive infected. So those are the introduction risks. And that's really where a lot of our work can help with, is like, when do you open schools to ensure that you're not opening in a situation where you're likely to have a lot of students or faculty show up on day 1 with infection. So what can you do to mitigate or reduce the likelihood that people are just going to show up in the first place infected? But that's also about symptom screening and testing if you have testing resources, right? So making sure nobody shows up on day 1 or day 2 or whatever it is. The second category of risk is on-campus transmission risks. And I think that's where a lot of your focus is. How do you mitigate the risk that if somebody does show up infected, that they will infect others? And that's, a lot about facilities, but also a lot about thinking about cohorting and distancing and masking and figuring out a way so that kids never have to eat at school. I know that's impossible, but that's the point where they take off their masks and they are talking, and that's actually a risky activity for schools. But it's little things like that in addition to facilities. And then there's the risk that I think public health agencies are somewhat thinking about. I think schools are maybe thinking about to some extent, but I think it's being neglected a little bit. And that is what is the risk that what happens in school will amplify risk throughout the community. So what is, as if indeed transmission happens on school campuses, how many other people are going to be downstream cases, right? That got infected because someone brought it home and then brought it to work and brought it to the community. For every transmission event that happens in school, how many deaths are going to occur in the community or hospitalizations, right? And that is something where the kinds of models that we do can help inform that, but there hasn't been a lot of work on that yet, but it's an important thing to think about. Okay, so let me just say a few words. So we have thought a lot about, at the request of our state agency and our local school districts, we have thought a lot about, when should you start opening schools? And this is a screenshot from an interactive map that was published in the New York Times on July 31st. And this is a map that's based on a very simple model that we built in my group. And it basically, for every county in the United States, it estimates, and it was based on the conditions in the United States right around July 31st, it estimates the number of people who will show up at a school infected in the first week. And that's student, staff, anyone, based on how many people are going to actually come to school. So if you look on the bottom, you can see there's these like 4 boxes. It's a pod of 7, a school of 100, a school of 500, a school of 1,000. You can click on those boxes and then see what is the estimated number. And there's 2 things that go into the color on this map. One is how big your school is. The more kids in your school, the more people coming to school, the more chances there are someone will show up infected. But also really critically, it depends on what part of the country you're in. And, where the part of the country I'm in, Texas, things are really red. I think in Hillsborough, things are looking a little bit more positive, right? So I think it, really depends on what the part of the country you're in. And we know that the situation around the country is changing on a daily basis. So, these estimates are already out of date, but I'm going to talk in a minute about how, you can look at data from your own community and approximate these risks. So this kind of calculation is something that we have made, on many different scales, many different things. And the math that goes into this, it's pretty simple. And it's the exact same math that goes into, what happens if you have a football game and 25,000 people show up? What's the chance that someone will show up infected? It's really just based on how much virus there is in the community. Okay, so let me see. So I am gonna just tell you, I'm gonna go through a quick calculation that I just provided yesterday for a local school in Austin to help them think about when might it be reasonable to start bringing small groups or larger groups to campus based on the conditions in Austin, and this would apply to any city. Up until, I would say yesterday, when a school finally kind of said, please give us a threshold, we were hesitant to say, we'll give you a threshold. We were providing information. We were saying, hey, here's the risk. It's likely, given your school size and your community, it's likely you'll have 2 kids show up in the first week. But you have to decide what you want to do with that information, right? And it's hard to make that call. Like, when is it safe? And we really don't know when it's safe or feasible. And it really, safe and feasibility has to be decided in the context of what are the costs of not bringing those kids to school, given the educational costs of not providing education and social services and all those things, right? So this is a possible threshold I'm going to talk about. It may not be appropriate for you. And certainly it's not hard to make these kinds of calculations for other thresholds. But let me just give you an example of a possible threshold. So how would we go about this? First, I'm going to tell you just like, what do I mean by threshold? So the first thing you would want to do before I tell you what the threshold is think about what is it we're going to compare to the threshold. Well, one thing you can look up on a daily basis, for example, New York Times provides a daily update of this. I believe Johns Hopkins also has a daily dashboard, and your own public health, either your local or your state level public health department may also provide this number. But a good number to look at that tells you something about the prevalence of the virus in your community right now is just the number of cases that have been confirmed per 100,000 people over the last 7 days. So basically the last week, how many new cases have there been per 100,000 people in your community? And the New York Times gives this as a per 100,000. They do the division for you. So for example, New York Times, I think I looked this up this morning, Durham County, 77 cases over the last week per 100,000 people who live in Durham County. and Hillsborough County, 32 cases per 100,000 people. Okay, so we're comparing apples to apples by dividing by the size of the population, right? Okay, so now let's talk about the threshold. So this is one possible threshold, and this may not be appropriate for your school for a variety of reasons, but here's one possible threshold. What you want a threshold, you know, how many cases, a threshold in terms of cases per 100,000 last week that would ensure less than a 50% chance that even one person will arrive infected. Okay, that may be too stringent for you, but if you really want to kind of sort of close to a zero tolerance policy and you want to make sure like in that first week you're not already having to send people home, this might be a reasonable threshold. Doesn't guarantee nobody's going to show up, but less than a 50% chance even one person shows up. You know, chances are you're not even going to have one case. It's not super stringent, but it's also, you know, it's not super lax either. Okay, so it's a reasonable, but maybe not totally appropriate for you. So how do I calculate that? Well, it's going to depend, what my threshold is going to be is going to importantly depend on the number of people who are in my school, and it's not really the number of people total in my school, it's the number of people who I think I want to bring to school that first week. So if you're cohorting or bringing one grade at a time or whatever it is, it's actually the number of people who are going to be at school, so students and faculty and staff. And then there's this other number that's going to go in the calculation, and that's the case reporting rate, and that's the place where there's going to be a little more guesswork. So when I say, you know, when you look at the top and you see 77 cases per 100,000, that's 77 cases reported, not 77 people infected, right? These data are just based on how many reported. And we've estimated, and others have estimated that, you know, the reporting rates, the fraction of cases detected, varies widely across the country and also has changed through time. And, you know, if you've heard in the news that now the CDC has changed its recommendations for who gets tested, we may see different, you know, lower fractions of cases actually detected. So, but right now, we've estimated in Texas that reporting rates range from 1 in 3 cases to about 1 in 10 cases reported, with a median about 5. The CDC has suggested people use around 1 in 10 cases, you know, so that would mean for Durham County, there's 77 cases reported per 100,000, but maybe today there's more like 770 people infected per 100,000, right? And so we're going to want to account for that underreporting and making this threshold calculation. So the threshold calculation, in order to get this threshold, so you are ensure that lower than 50% chance that even one person will show up infected, happens to be 69,000. That comes from this 50% chance thing, times the case reporting rate divided by the size of your school. Okay, so that's it, and that's for this particular threshold. So let's do this exercise for Durham and for Hillsborough. So we're going to go ahead and compare the 7-day case counts, that's 77 and 32, to the safety threshold that we just came up with. And I'm going to make the assumption that the case reporting rate is 1 in 10. That's slightly conservative. That means that if you actually have a higher case reporting rate, like if it's more like, you know, 1 in 5 or 1 in 3, you actually could have a higher threshold. You actually could come to school earlier or whatever, right? So this is going to be a little more conservative and ensure that you're not coming to school too early. You're maybe overestimating a little bit the prevalence in your community. So assuming that 1 in 10 cases is detected, so that value of C is equal to 0.1, these are the thresholds I get for different school sizes. So if I'm going to bring 25 kids to school, then as long as my 7-day confirmed cases below 276, I'm going to be ensured that there's, you know, lower than a 50% chance that I'm going to have a case in that first week. So in other words, since Durham's at 77 and Hillsborough is at 32, those are both well below that 276 threshold. Today, it probably is reasonable to try to safely, cautiously bring 25 kids to campus. Same with 50 kids. But as soon as we get to, you're both under through 75. So Durham, it looks like you could bring up to 75 kids to campus safely, right? Because 77 is less than 92. It might not be wise to bring 100 kids or more to campus. And it looks like Hillsborough with that 32 could go up to maybe bringing 200 kids to campus, where the threshold is, you know, 35. You guys following how I'm reading this chart? Is that right? The thresholds are on the right. I'm just making sure my number is below that number on the right. So Durham is below the threshold for bringing 75 to campus. and Hillsborough is below the threshold for bringing 200 to campus. And if you look at the trends in your own community, and I did look to see what kind of data are available in your communities. I believe Durham County has the local health department provides the time series of cases locally, and you can also look at the New York Times. But it looks like, you know, at least Durham is on a downward trend. So, but I don't know when you're planning to open your schools, but things might even look better a couple weeks from now. So, you know, keep an eye on things. So my last slide is really kind of just basics, and these may be things you already know so well. So I'll kind of whiz through it, but this is just from my perspective, you know, some of the things that have come up in a lot of conversations with schools, with our local public health department. So, you know, it'll be difficult to close schools and to open schools and keep them open without interrupted service, without interrupted education until the local prevalence gets close to zero, you know, and those thresholds are pretty low for when it makes sense to bring kids to campus. In Austin, this happens to be output from a model we're doing in Austin. We estimate that today we have about 2 cases per 1,000 people. So that means if we have a school of 1,000 people, it's likely 2 people will show up in the first week infected. Durham, actually, based on your latest data, it looks like you're at about the same point, about 2.5 per 1,000 people. Hillsborough is much lower. It's less than 1 per 1,000 people at this point. It's really valuable, if you haven't already, to look to your local health department or your state health department for guidelines. Some of them have done a really good job of synthesizing all the science, all the examples, and providing flow charts, visualizations to guide schools, to guide parents, to guide teachers towards the safe reopening of schools. My own local health department, Travis County Local Health Department, has a really great document that they've put together to guide local schools. It's available online. I think it's worth looking at even if you're not in Austin, if you haven't been able to track down a good resource. And, you know, both the National Academies report and the CDC, they really emphasize establishing a strong partnership between schools and local health departments. So that because of this, you know, very interconnected system we're in, right? What happens in schools will impact what happens in the community and vice versa. And local health departments, sometimes they have expertise in health, you know, really about the epidemiology of the virus, and certainly have a network of connections to people who are really experts about controlling the spread of this virus. And so if you haven't found a good document, I recommend Austin's, but I'm sure there's others that are very good as well. You know, I think taking baby steps and prioritizing by need. If you're in a community where it doesn't feel safe to bring everyone on campus at once, you know, thinking about what are your highest priority students to bring to campus in terms of their, you know, educational needs, their social needs, et cetera. And try to, you know, really rank order and bring them on slowly and see how things go, and also prioritize which teachers should probably be staying home based on risks and needs as well. And then here's some key strategies. You know, the extent to which, particularly in communities with high prevalence, the extent to which you can cohort teachers and staff will really go a long way. So what does that mean? That means, you know, creating small groups so that the people in those groups only interact with each other and they don't interact with other groups. That not only makes it less likely that the virus will spread far if somebody shows up infected at school, it also just makes the response so much easier. If you know that a student has only interacted with 9 other people in your community, there are only 9 other people you need to potentially quarantine, and maybe they're siblings or whatever, but it just makes the response that much easier. And it's important to think kind of holistically over the course of the whole day. If you're in a community where your kids go to school and then they do after school sports and then they do after school programs and then they have siblings and whatever, you know, really think through how many different cohorts throughout the day is this child involved in, and are they really only interacting with 9 other people, or are they interacting with 90 other people? And, you know, the extent to which you can kind of organize along those themes or prevent these extra activities will also reduce the risk of transmission and importations. Face masks, face masks, face masks. You know, there's like strong consensus that that is a really key way we can reduce the risk of transmission. And it does seem like, you know, one of the, as I mentioned earlier, one of the key points in the day where there may be opportunities for kids to take off face masks and spread virus is when they're eating. And so the extent to which they probably have to eat unless you're sending them home before lunch. If you can really enforce distance when the kids are eating, I think that's really can go a long way. Ventilation, and this is, I know what you want to talk about more, and where I don't have as much to say, but wherever possible, if you can move things outdoors and open the windows, you should. I'm sure you know, but one of the resources that I have used when trying to understand more of these issues that you're facing is the ASHRAE guidelines. I'm not sure if those are on your radar, and I don't know if those are what you think are the sort of industry standards, but that's been a useful resource for me in trying to understand a little bit more what's going on in your world. In thinking about how you're going to approach this, I think thinking about it not just from the perspective of students, but also keep the health and safety of your staff and the health and safety of your community, which we talked about earlier. What happens in schools impacts the community. If you are going to try to do strict cohorting, it may require a lot more staff. And if resources are available to help schools to do this safely, that may be a place you want to think about investing, so that there are just more, you can break your kids down into more groups. And I think thinking about how you're going to support working parents when you do have to quarantine, or when you do have to send kids home. For some parents, it's going to be very difficult for them to stay home and isolate their children, particularly for young children. Can your community, can your school provide isolation facilities for children, so that parents can still go to work when you have an asymptomatic kid who has to stay home because somebody in their cohort was sick? So is there a way your community can support it so that parents don't have to make decisions where they're having to choose between kind of health and safety of the community and putting food on the table? And then things that are of more limited efficacy, but I don't know why I said limited, but okay. So one thing is symptom screening is really valuable. Absolutely, it should be done. But as we've discussed earlier, there is a lot of pre-symptomatic transmission. And we know that probably the vast majority of children who get infected won't have many symptoms at all. And so you're going to miss a lot of cases if you just rely on symptom screening. One thing that you could do to improve the efficacy of symptom screening is to expand it to doing family or household symptom screening. If a family is infected, if more than one person in the household is infected, you're more likely to see a symptom among an adult in the family or early, than among a child. And so if you symptom screen, say, does anyone in your household have symptoms, you may be able to catch some cases that would otherwise kind of slip through the cracks if you're just doing symptom screening for the children. And then also, testing can be an amazing tool. And if you're doing it frequently enough and you're getting results quickly enough to really, detect cases before they walk through the door, or detect enough cases. But given current resources in many communities, testing is going to have limited efficacy. And I believe, that was actually it for my thoughts, and I'm happy to take it from there.
Thank you very much, Dr. Meyers. One of the questions that came up, because for those of us in the room and who want to reproduce your math, could you go back to how you started with that $69,000 base point to multiply by your case rate and your S value, and then secondarily on the case rate, are you recommending that we consider the non-reporting factor on top of that of anywhere between 5 and 10, or use the reported value?
Okay, so the 69,000 comes from a little bit of complicated, not super complicated, but it comes from doing a little bit of math around wanting to ensure the 50% chance that not even one would arrive infected. So if I change that to 90% or 80%, it comes from there. And so, and I'm not going to go into the details of the math, but that number only works for the 50% chance thing. Okay. So then the question of what to assume. So I do recommend using somewhere between, if there's any information from your own community about what the case reporting rate is, you can use that value. I think a conservative number to use is 1 in 10. So that means setting C equal to 0.1. A less conservative, like I said, in Texas, the median case reporting rate across like our 22 sort of regions of Texas is 1 in 5. So meaning like for every case that is reported, there are probably 4 other unreported cases, untested cases. If you wanted to use a 1 in 5, that would mean setting C equal to 0.2 instead of 0.1. So, and I think, you know, sort of the best case scenario is maybe you're catching 1 in 3 cases. So then you could put your C equals to 0.33. Okay, so that's kind of the idea. So the C is equal to the fraction of cases that you think are being reported when you look up the 77 per 100,000 or the 32 per 100,000.
Got it. Okay, thank you very much.
Sure.
Okay. All right, so I'm going to, and this is being recorded, so you all can peruse these calculations and recording again. So I'm going to go back to the presentation. And in the remaining time that we have here for our conversation today, wanted to get to some of the questions, and I'll let Julius and Bill take over in the conversation directly with Dr. Meyers. Generally speaking, the questions that they discussed with me prior to this call was, one, filtering facts. There's a lot of information. What are the basics? What do I need to know to filter through that and pull the wheat from the chaff, so to speak? Secondly, filtering air. And it notes they're not asking HVA specific questions, but I guess that the crux of the question is there a point in which a lack of ventilation in a room in and of itself precludes that room from being wise to use this for instruction? Or if you are following these other metrics about, you know, keeping your limited, only opening if your numbers, according to the calculations you just showed us, are lining up. If that's in check, you are doing social distancing, you're using PPE, is any space viable, or is there a point in which some aren't? And then let's go from there.
Okay, do you want me to jump in on this?
Yeah, jump in, and then Julius and Bill take over, please.
Okay, so I'll be quick. So filtering fact from fiction, yeah, there's a lot of noise out there. I would say, again, local health department, CDC, state health department, you know, they are a reliable source of information just about the basic epidemiology. Sometimes they're a bit out of date. They're not necessarily incorporating the latest developments in science, but I think they're trying to keep up, and some health departments really are being proactive about trying to guide schools. So I look for, you know, resources on validated public health websites. And then with respect to, like, is there kind of a bottom line, like this kind of room, just you got to take it out of commission? And unfortunately, I just don't know the answer to that. And I don't know if there is an answer to that. I think that whatever, you know, again, you know, the more, if you have a choice between bringing kids outdoors and maybe a suboptimal setting because there's no blackboard or whatever we use these days, and putting them in a room like that, maybe opt for, you know, sending them outside if you have a choice. Certainly, if you know, even if you go below this threshold, I mean, I want to emphasize that you still may very well have a case show up in the first week, and
Sure.
and depending. And so I think you have to still operate under the assumption that someone's going to show up at school infected, and you just want to make sure you're taking all the steps possible. And so that does mean, you know, really face mask as much as possible, everyone, no matter how young they are, if you can, and keeping distance. You know, if you can really ensure that 6 foot plus distance between students all day long, and cohorting, you know, that will go a long way.
David, if I could just say, first of all, thank you to Dr. Meyers, because as an operations guy, this is the first time in a long time that anyone's produced any type of calculation or rationale that we could use for a matrix in trying to navigate whether or not we're going to bring students back. So first of all, let me say I appreciate you providing that. I think one of the other questions that continues to pop up, at least in my district, is and you mentioned part of it, the new guidance from the CDC as far as when and whether you should test people. I think that has been a constant moving target as we try to implement or operationalize these different guidances. And it has become very frustrating for not only central office staff, but even at the school level, and I'm sure for families as well. I was on a call with a superintendent last night, and her comment was, teachers are planners. They like to plan out things by nature, and they like to have a long view of things. And with these ever-changing guidance that we're receiving from many different agencies, CDC, OSHA, and then our local health department, state health departments, different state health departments saying different things. What do you suggest we use to really filter through that noise and get down to what it is that we need to do and implement so that we can get our students back into our schools?
Yeah, it's hard for me to say. I don't know if you have a good relationship with your local health department and feel like they're a trusted authority. Like, I think it's good to find someone relatively local that you trust. And if all else fails, I guess, go to the CDC, to the CDC's guidance. I think that, the current testing situation is really difficult to understand where it's coming from and how it's going to impact things. But I think it probably makes sense at this point, given that there's a lot of uncertainty right as schools are about to open, to think about what is the plan if basically your community is not going to have access to rapid testing, at least, for asymptomatic people. And for example, in like Austin Public Health guidelines, they talk about how to handle a case with symptoms that's not tested, or a case or somebody who was in the room with someone with symptoms who is not tested. And so, just kind of think through the flow chart of, under the assumption that you're not going to have access to testing, a lot of testing, unfortunately, what's going to be the game plan when you do identify a case in your community?
Dr. Meyers, up here, we seem to be going through, we've gone through our questions, but now it's sports. So, you have the camp that says, hey, it's okay to play golf, it's okay to play, or have cross country. And then you get the soccer and the football teams and coaches that are saying we want to play. What's your thoughts on bringing sports back, if at all, or do we wait until the spring or after this is all done?
Yeah, my thoughts are, it's depending on the sport and depending on the prevalence of the virus in the community, it can be a very risky thing to do, right? The more close contact the sport is, the less able the kids are able to wear face masks, which is going to be the case in a lot of sports. And the higher the prevalence, the more likely it is that sports will lead to transmission. It's sort of an eyes wide open thing. If people want to participate in sports, they need to realize, or they want to, have sports happen in their communities. They need to realize, what the risks are that will lead to transmission, but not only between the players, but importantly, those players who, bring it home to their families and to their communities. So I think there certainly are some sporting activities that are less risky, ones that where people can keep things like cross country, where the kids might be able to keep a distance, or others where people can keep face masks on, et cetera, be safer, but it's sort of the same ideas, right? If people are coming in close contact without wearing face masks, there's going to be opportunities for transmission. And you got to think about kind of people who are connected to those communities. And the other thing is, I think one thing to think about is locker rooms might be an issue. And so I think the extent to which you get the kids already dressed, you show up dressed and send them home afterwards, it can also help with some risks.
Can you speak a little to face shields and face masks? And so the reason why I ask is what we're hearing back from our academic side of the house is it's very difficult to teach in a face mask or a face covering that's covering the mouth, especially at the lower grades when they're trying to teach children phonics and they need to see it, as well as some of our exceptional children are hard of hearing. And so the request has been that maybe we could use the face shields But we've been hearing conflicting reports about whether or not, even if you wear a face shield, if you should still wear the mask. So can you speak to some of that for us, please?
Yeah, my understanding from the little like definitive research there is that face shields are not as effective at preventing transmission as face masks are, and they are not recommended as an alternative to face masks. And so, I think, I imagine there's some innovative educators who are thinking about some of the challenges of trying to deliver effective education with a face mask. If you have certain special needs kids and you really can make the cohort small, where the teacher is only interacting with a couple kids and just those kids, and maybe that's a little safer to take off the face mask, keeping your distance. You've got your little small community. Doing some of these lessons that really require looking at each other's faces close, doing those online, deciding what are you going to do online and what are you going to do in person. But it is a challenge, and I don't think I don't feel comfortable saying, sure, in those situations, just use a mask instead of use a shield instead of a mask, because the evidence is that they're not as effective.
Dr. Meyers, you were talking about face masks earlier and the high risk when they're eating in classrooms or in the cafeteria. So over here in Milford, we're saying, everyone's wearing a mask all day when they get on the bus, when they come into school, and then they're giving them a 10-minute break every hour. So what I'm thinking about is, if they take them off and they're in the classroom, what good is it? There seems to be if anybody's asymptomatic and they have it, they're going to spread it. So we have, winter time hits, we can have that. It happened in October for Halloween. We had 10 inches of snow. Would it be advisable to tell the staff that they need to take the kids outside for that 10-minute break so they can keep everyone, socially distanced and they're breathing fresh air? Because it just seems like if we let them stay in the classroom or in the building, they have a higher chance of spreading the COVID.
Yeah. I think that if you keep the kids in kind of relatively close distance and you let them take their face masks off for 10 minutes, it does introduce a real risk of transmission, just like you're saying. And so, I think, creative solutions to this. I don't know what they look like. Certainly having the kids go outside at a farther distance with their masks off to take a break. I don't know how you handle the winter. Maybe there are ways to space them out more indoors, or to let them go one by one in the bathroom, or I don't know, where there's a special room where they get, they can go one or two at a time. But yeah, I think it's a challenge, and I think it is risky to be in a room where you say you have to wear face masks all the time, but you can take them off for 10 minutes. It's also just hard for the students to understand. Then why do I have to keep it on the rest of the time?
Right.
Yeah.
So, teachers pass out the tests. The students take them, and it's time to turn in their assignment. What's the likelihood that in the time that it takes for the student to, write something on that paper or whatever, do their work, and then pass it in to the teacher, that COVID-19 could be passed around that way? And then another question to that, what's your thoughts about disinfecting? Because a system like mine, we have close to 6 million square feet that we're maintaining, and cleaning is hard enough. But when we hear things like constant disinfecting of high touch areas, is there an expectation that every 20 minutes, teachers need to take a break? Maybe that's during the mass break, and clean off everything and disinfect it? Or is end of the day sufficient enough for that?
This will be our last question.
Yeah, I'm sorry, I have to go through this question, but yeah, I would say, this is getting into some of the details where I don't think I necessarily have an expert opinion. There is evidence of some what we call fomite transmission, on surfaces and stuff like that. So, if the teacher can avoid having the students walk up and hand the papers, they can leave them on their desk, the teacher picks them up, or just, ways to avoid it. I don't know what the chance is that if you have a student for 2 seconds show up, but just avoiding those things where possible, but not necessarily, if you can't avoid it, it might be okay. And then with cleaning, there are some strategies, like the children each have their own little thing of Clorox wipes and they wipe it down themselves. So the teacher doesn't have to clean all the time. They do. It was interesting. I actually didn't, one of the interesting guidelines that was repeated multiple times in the Austin Public Health's guidance to schools, which again, I want to emphasize is a good resource, is if there is a case or a putative case at a school, like somebody has symptoms, they go home, they recommend actually vacating that classroom that the student has been in and not going back and cleaning it until 24 hours after the student was already there. Just to kind of give it more time to air out and less likely that facilities folks will be exposed.
So, Dr. Meyers and Julius and Bill, thank you all very much for your time and the insights today. Conversation was very insightful. Dr. Meyers, great presentation. Really appreciate it. And yeah, thank you very much for your time.
Yeah, thank you all. Nice to talk to you and good luck with the schools. I know it's a huge challenge and appreciate you doing it for all of us.